life. Give it a chance. Give it a chance. Okay, so we're going to talk about the different receptor types. We're going to talk about the sympathomimetics, the sympatholytics, okay? So we're going to talk about the ones that mime and the ones that block. The major neurotransmitters of the SANs are norepinephrine and epinephrine, okay? Norepinephrine is actually the major neurotransmitter of the system, okay? It's what's released at the terminal nerve endings between the postganglionic fiber and the affected tissue, right? Remember, the norepinephrine is there. It's adrenergic, epinephrine, adrenaline, same thing. With stimulation, epinephrine is released from that adrenal medulla, like we talked about, when the SANs is stimulated by our body's response or by a drug, okay? And then it's distributed very diffusely throughout the body, okay? I actually think about the epinephrine, the norepinephrine, and it being sympathetic and having that diffuse response is when you are stimulated and the adrenaline's flowing, like your whole body's kind of going. So I think of it that way, having that diffuse response. Okay. There are direct acting, there are indirect acting, and there are mixed. Okay. So the direct acting goes directly to the receptor site, just like direct acting with the PANS drugs. In the indirect acting, remember the indirect acting released acetylcholine before. This time it's going to release the endogenous, our own body's norepinephrine, okay, which then would produce a response. And in the mixed, it can go on the receptor directly and release the endogenous norepinephrine and cause a response, okay? So direct acting, okay, drug goes right here, directly acts on the receptor site. Indirect works on the norepinephrine and has that have an effect on the receptor site. And the mixed can do both, so it might be a stronger response. Here's where we go, where we have our alpha and our beta. We have different types of receptors. They affect different tissues, okay? And the same tissues might have alpha and beta receptors, but depending on the drug that's used, different ones will respond, okay? They might be more selective to one or the other. The alpha, there's alpha 1 and alpha 2. The beta, there's beta 1 and beta 2, okay? Activation of the alpha receptors causes a different response than the activation of the beta receptors. It's very complex, okay? And there's variances of responses in the different subtypes. I'm sorry, but there just are. And when we learn about the different drugs and how they have an effect and why you should know whether it's an alpha or a beta, it will make a little bit more sense, okay? Remember talking about selectivity, okay, and non-selectivity. So when we talk about drugs being a selective adrenergic agonist, okay, so it's more selective. It's an adrenergic agonist, okay, so a SAN drug. It might bind to only one subtype of the receptors. It's more selective about who it binds to, okay? It only dates the people it likes, right? The non-selective might bind to more than one subtype, okay? Why might that be important? If it binds to more than one subtype. More side effects, okay? We might want it to bind to more than one subtype, but most of the time we want to have as discrete a response as possible, as selective a response as possible. So if it only binds to the subtype where we want to have the effect, great. If it also binds to another one, it might have more of an effect and different effects, okay? So selective drugs will have their therapeutic effect on the main target tissue they want it to. Non-selective drugs might affect more than one type of receptor and have more side effects. So as new drugs come out, they seek to make them more selective so we don't get these negative side effects. Great, okay? Non-selective, more side effects. Okay. Adrenergic agonists, okay, are used for cardiovascular effects. They're used for effects on breathing in the lungs, and they're used for the nasal passages. In this little chart that's here, okay, is to help you to remember the different types of receptors, okay, the adrenergic receptors, and what type of an effect that they will have. So the organ system is on the left, the sympathetic effects, that fight or flight effects it can have, and the receptors on the right. So when we're talking about cardiovascular, we've got both alpha and beta receptors. The beta receptors are in our heart, okay? Our big old heart. Beta 1 receptors. When we're talking about the alpha receptors, they are in our blood vessels. I always think, and I'll show you again, I always think of the alpha as the lumen of the blood vessel, okay, how open that is, and it looks like an A to me. So I always think of the alpha on my blood vessels like that, and I think of my heart being more bulky, and I think of the B there, okay? In our lungs, we have beta 2 receptors. This one's easy. How many hearts do we have?
1.
Beta 1. How many lungs do we have? 2. Beta 2, okay? Our blood glucose, okay? So where's glycogenolysis take place?
Liver?
Liver, okay? Is a beta 2, okay? Increased release of blood glucose, okay? That is an adrenergic sympathetic effect. GI tract, okay? Decreased GI processes, okay? There are alpha 2 and beta 2 in our GI tract, okay? When it comes to our bladder, okay, I think of that as kind of a muscle in there that can get contracted or expanded. That's also an alpha 1. It's helpful to remember these. Not hard to learn these. Okay, so our alpha receptors, let's go with those first, okay? There's my A, there's my lumen, okay? Stimulation of the alpha receptors causes smooth muscle excitation. When you excite a muscle, it doesn't expand, it contracts. Okay, contracting a muscle makes it do something. Okay, smooth muscle excitation causes vasoconstriction. If I excite the muscle in my blood vessels, it's going to constrict. Think about pushing the blood around. Okay. Alpha receptors are also located in skin and skeletal muscle, and therefore it causes vasoconstriction of the skin and the skeletal muscle if it's stimulated. Muscles contract in the blood vessels, they contract in our skeletal muscles as well as in our skin, okay? If drugs block the action of the neurotransmitters on the alpha receptor, they're called alpha adrenergic blocking agents, right? It's stopping that from happening. Okay, so there's my alpha, okay, my A. Stimulation, and this is a lumen of the blood vessel, right? That's all muscle that's in that wall of the blood vessel, okay? It causes vasoconstriction by contracting it. Doesn't it help to get that picture in your mind? It's like my A, it's got the muscle in there, okay? If I block that, I cause vasodilation, right? Vasodilation. Beta receptors. Beta 1 are in our heart, okay? Stimulation of the beta receptors, the beta 1 receptors, causes a positive chronotropic effect, okay? Increased rate, and a positive inotropic effect, increased strength of contraction, okay? We also talked about the metabolic effect on glycogen formation, glycogenolysis in the liver, blood glucose for energy. Stimulation of the beta 2 receptors, okay, results in smooth muscle inhibition or relaxation. So stimulation of the beta 2 causes vasodilation, of the skeletal muscles, and relaxation of the smooth muscles of the bronchioles and the lungs results in bronchodilation. Okay, so opposite effects on the muscle and the bronchioles, right? Think about that person running through the woods from the bear. The bronchioles were dilated, but the heart was going, right? So we had that positive effect on the heart and pumping up the blood, the inotropic, the chronotropic effect, right? The constriction of the blood vessels, all right? But the bronchioles were dilated. Drugs that block the beta adrenergic agents are called beta blockers. Sounds familiar from the heart medications, right? Some are non-specific and block the beta 1 and the beta 2, and others are more selective, blocking only the beta 2 receptors. So if you're giving an asthma medication and it blocks both of them, that wouldn't be good, would it? Okay, because it's going to have a negative effect on the heart. So somebody with heart disease might want to take an asthma medication that only is selective to the beta-2 receptors, so they can get the bronchodilation, but not get the vasoconstriction, right? See the selectivity, non-selectivity? Okay. What about the adrenergic sympathomimetic agents, okay? What are their effects, negative effects, all of that. The sympathomimetic agents are important, as we talked about, in asthma medication, okay? And also in treatment of anaphylaxis, anaphylaxis being what?
Shock.
Could happen from allergies, shock, okay? It's an extreme allergic reaction, you're all right, okay? And also in asthma. Adrenergic agents are added to local anesthetics, right? To cause vasoconstriction and prolong their action. So if we put in a local anesthetic and there's a really, really good blood flow to the area, it's going to take and metabolize that agent, and we're not going to be numb as long. If we put a vasoconstrictor in with the local anesthetic, the blood vessels do this, they shrink back from the tissue. We also get less what? Bleeding, okay? So less bleeding, longer action of the local anesthetic. That's why it's in our local anesthetics. Talk about that, okay? Okay. The adrenergic effect. The adrenergic drugs, okay, they have alpha receptor and beta receptor responses, but we hope that they're going to be a little bit more selective, okay? There are different kinds. Epinephrine in itself is non-selective, so it has both alpha and beta receptor activity. It's non-selective. There actually used to be, it was over-the-counter, an asthma drug called Primatene Mist. I don't know if that sounds familiar to everybody. People could go to the store and buy this stuff. And it was wicked on the heart. I mean, there were actually heart attacks that were traced to and whatnot, because it was epinephrine that was in it. Okay? Norepinephrine, okay, primarily stimulates alpha receptors. So when we talk about their effect, we're going to talk about alpha effect and beta effect. Sympathetic agents, okay, such as amphetamines, sound familiar, okay, produce central nervous system excitation, alertness, okay, we know about amphetamines. Back in the 70s, I think they called them uppers, okay? So they act like the sympathetic autonomic nervous system would, okay? They cause that kind of alertness and excitation, okay? With higher doses, there's overstimulation, restlessness, and tremors, okay? So too much of a sympathetic agent can cause this CNS excitation and tremors and shaking and that sort of thing. That's one of the toxic effects of it. We know that the pharmacologic effect on the cardiovascular system of the adrenergic agents is going to be that increased force and strength of contraction. The norepinephrine, okay, which is an alpha agonist, means it works on the blood vessels and constricts them, okay? Increases if you constrict a vessel. Okay, so let's think about this. The heart is pumping, and if you pump the heart and you constrict the vessels, when the heart goes to pump out, is there more or less pressure on those vessels when it's coming out of the heart?
More.
More. That's peripheral resistance. So it increases peripheral resistance, which drives the blood pressure, the pressure on the blood vessels, up. Okay? Epinephrine, an alpha and a B agonist, okay, beta agonist, constricts the alpha receptors and the beta receptors, okay? And dilates the beta receptors, okay? Weirdness here. So, it widens the difference when you're taking a blood pressure. Did you ever, you guys haven't probably taken a whole lot of them now, but you notice that usually if the blood pressure, when you're looking at the diastolic and the systolic, right? Systolic and diastolic, that they're both up at the same time, right? But you might have a patient who has a bigger difference between their systolic and their diastolic pressure, and they actually call that difference the pulse pressure, and it's weird, okay? You're gonna think that's very weird, but it could be that that's an effect of a drug that they're taking. There's a wider difference between them, yes?
Like when I was taking my dad's blood pressure, one day he came to the clinic and he didn't take his medication, the other day he did. His systolic was kind of the same, but the diastolic was way lower when he took his medication.
That's a wide pulse pressure. Yes, so something's a little bit off there. Yep. So you may notice a very wide pulse pressure when someone's taking this type of a drug. Okay. On the vessels, there can be a mixed effect, okay? So if they have agents that have primarily alpha receptor effects, okay, the vasoconstriction can happen primarily in the mucosa and the skin. If they have beta receptor effects, it can produce the vasodilation in the skeletal muscle, okay? Mixed effects. The resulting effect on that peripheral resistance we talked about is an increase with alpha receptor agents, okay, and a decrease with beta receptor agents, just because of the different effects they have. Again, this whole thing right here, we'll worry about it when we talk about a specific drug, and then we might need to revisit it to talk about why that drug has that effect on alpha and beta, okay, because it's non-specific. That's what we'll be talking about. Don't worry too much about it now. Okay. What about effects on the blood pressure? The sympathomimetic effects on blood pressure is generally an increase, right? Epinephrine causes a rise in systolic BP and a decrease in diastolic BP. Norepinephrine causes a rise in both the systolic BP and the diastolic BP, okay? Depending on their effect on both. How about on the eyes? Okay, we already knew that the parasympathomimetic, their effect was to meiosis, right? Constrict the pupils. So the sympathomimetic agents, okay, can cause dilation of the pupil and decrease the intraocular pressure, okay, for people with glaucoma. What about the respiratory system? Again, we already talked about this a little bit. The sympathomimetic agents relax the bronchioles, okay, they cause bronchial smooth muscle relaxation, okay, and dilation. So this is useful in treating asthma and anaphylaxis. Ultimately, people die from respiratory arrest from anaphylactic shock, okay? So this is useful for treating those. Okay, metabolic effects. Because of the dumping of the glycogenolysis and the dumping of blood glucose into the system, okay, beta receptors being stimulated, we increase blood glucose and insulin release as well, okay? So more glucose goes into the blood with an adrenergic response. Okay? Salivary glands, okay? We know that the cholinergics cause that thin, watery, profuse saliva. The mucus secreting glands that are stimulated by the adrenergic causes the thick, viscous saliva. Not very good for getting the mouth feeling very wet, okay? So the general effect would be xerostomia because of the thick mucus effect, okay? And the parotid gland is not stimulated by it. That would be the cholinergic drugs, okay? So either very little saliva, very little thin saliva, thick mucus saliva, and xerostomia.